My name is Erin Hertzog. I'm a partner at Foley Hoag, based in Washington, D.C., and we'll have everyone in the panel introduce themselves, and then we'll start off with an intro of the IRA before we dive in.
Sure. Hi, I'm Leslie Wood. I'm Regional Vice President of State Policy at Pharma. I have responsibilities for the eastern half of the country, and looking forward to the discussion today.
I'm Nick Shipley. I'm the Chief Advocacy Officer at Bio, and I have responsibilities for state and federal. And like Leslie, also looking forward to talking about IRA.
I'm Duane Schulthess. I'm the CEO of Vital Transformation. We're a health, economic, and strategy consultancy based in Brussels and Washington, D.C. And I'm looking forward to the panel, but you may not be after I get done, so we'll see what happens.
Yeah, Duane's full of bad news. So before we get started with the questions I have for the panel, I thought it would make sense to just level set a little bit about the IRA. I think most people in the room are probably pretty familiar with it, but just to make sure we're all on the same page. The Inflation Reduction Act, in particular the drug pricing provisions, which was enacted last August, has sort of three main relatively significant changes to the Medicare program when it comes to payment for pharmaceuticals. The first and probably most significant piece of the law, which is going to be really the focus of today's discussion, is the negotiation program. And essentially what this part of the law did is it created an exception to the historical non-interference clause in the Part D program, which historically had barred the Secretary of Health and Human Services from interfering in the negotiation process between Part D plans and manufacturers, to allow for and actually require the Secretary to negotiate directly with manufacturers of certain what are called selected drugs in order to establish a maximum fair price for each of those products. And the first cohort of drugs, which is going to be 10 Medicare Part D, so largely small molecule products, that are being selected this year, and then there'll be a negotiation process over the next several months, and those products will then have a negotiated price that takes effect in 2026. And while that sounds like a relatively long lead time, this year has been already very busy with IRA implementation efforts, as we'll be talking about. And then the other two parts of the law, which we're not really going to talk about, but I think is important to sort of know about for context. The law also created mandatory inflation rebates, which essentially penalize manufacturers that take price increases that exceed the rate of inflation. The Part D inflation rebates took effect last October, and the Part B inflation rebates took effect this January. And then the last part, which is maybe a little bit less doom and gloom than what Duane is going to talk about, is the Part D redesign. So the law made significant changes to the way that the Part D benefit is structured. And the sort of the upside of all of it is essentially reducing beneficiary cost exposure in the Part D benefit, but does sort of shift around responsibilities for sort of who pays for what in Medicare Part D in a way that's potentially going to significantly, or will I think significantly change incentives in terms of sort of how formularies are designed and what products beneficiaries have access to, and potentially also increase the rates of utilization management and other tools that Part D plans use to minimize access to certain therapies. And so I should say we're going to kind of go through the presentation, and then there will be a fair amount of time, about 20 minutes, for questions and answers at the end of the session. So if everyone could sort of hold their question until that point, that would be awesome. So I think now we'll turn to sort of the Q&A part, and I'll start with Duane. Duane, can you give us an overview of the impact of the IRA on innovation as well as jobs, with a particular focus on Massachusetts?
Sure. I'll start high level and then drill down to Massachusetts. What we did is we looked at the recent update from CMS that came out last month. And what we found was about 220 drugs that we thought that theoretically could put through the pipeline. We built an economic model called a Monte Carlo model, where we walked it through the pricing provisions of the IRA. And what we found was 41 firms would be impacted with 92 different therapies. And just at the top line macro revenue level over 10 years, we're looking at a 40% loss of net revenue. I'll say that again, a 40% loss in the 41 firms. So the firms go from 190 billion to 113 billion in the final year of the markdowns by the time you get the pricing controls in based on the 9 and 13 year inclusion and negotiation. Now, you may think, well, 40%, that's bad. And it is. But the problem is it's not concentrated equally across the whole cohort of 41 companies. It really rests at the real upper end and 1/4 of the companies, they lose about 300% of their net earnings. For those who missed that, I'll cover that again. They lose about 300% of their net earnings. Now that's unweighted, that's just on an average across the cohort. We did it weighted, and the upside is it's only 200% of net revenue weighted. So unfortunately, about 10 of the companies of the 41 get absolutely housed. There really are just a few drugs that are dominant in the sector, as we know. There are a few drugs that do a lot of the innovation, and unfortunately they sponsor a lot of the R&D investments. And the IRA is really going to impact a real small minority of these drugs, unfortunately, that are produced by very few companies. So I've been reading a lot of comments about CEOs saying, well, it's not that bad. I don't think the IRA is not that bad. And our answer has increasingly been to our clients, yet. But as your pipeline moves, unfortunately, the bell will toll for thee. It's inevitable somewhere along the line, if you have a blockbuster, you're going to get sucked into this thing. So what does that mean? Well, on average, about 25% of every dollar that's earned in sales goes into R&D. It's about 40% for biotech and about 20% for large pharma. So you take the average, it's about 25%. In our cohort, it's 28%, which is pretty close. So you can actually model the revenue impacts based on the numbers of Damasi or Jayasundara or Prasad. You can take sort of industry standard metrics and say, okay, what do these revenue losses mean practically? So if you look at the companies who are impacted by this, we project a loss of 40% of the assets in the company that are going to be touched by this. So we saw 92 assets produced by the companies who are going to be impacted and lose assets. So we go from 92 to 55, that's a loss of 37 new therapeutics that we are projecting based on revenue losses, depending if we use the Damasi or the Jayasundara numbers. Overwhelmingly, 75% of the portfolio, even though this was designed as what we jokingly call internally at my firm the Get Humira bill, which was really focused at trying to put the clamps on Humira and what was seen as the long tail in the intellectual property. The irony is now we're going to have 6 biologics coming out by next month for Humira, and it overwhelmingly hits 75% of the drugs are small molecules. So what we've done is we've looked at post-marketing study on small molecules, and we've found that there are 455 post-marketing studies, and these are things done by academics to see where they want to apply for NIH funding, et cetera. We can find no examples in the post-marketing work that we've done of an academic study that's doing large molecules for neurology. There's a big zero there. So overwhelmingly, the impact we're seeing on all the innovation now in neurology to cross the blood-brain barrier is in small molecules. And this bill really targets that innovation. So overwhelmingly, this is going to have a real deleterious impact, we feel at our firm, on small molecule innovation, particularly in the neurology pipeline, because we just don't see much evidence. Obviously, there's a lot of that going on in the companies and the large molecules. Great, they're expensive, they're hard to do, but a lot of the research is in small molecules. So there's really a huge impact here that's been overlooked in neurology, we feel. Now, what does this all mean for Massachusetts? If you look at these losses, and again, taking that 40% net macro loss of revenue across the cohort, we're using the IMPLAN model, which is by Techonomy. It's a model that pharma uses, we use it. It's a weighted model looking at various multipliers from the Bureau of Labor Statistics, so we scale this up. It's a 2017 model that we scale up to 2023. It's a good proxy. We see in Massachusetts somewhere between 5,000 and 10,000 direct job losses and 24,000 to 47,000 indirect job losses. Massachusetts had 10 years of investments into small biotech companies, such as many of your companies here today, 41 deals at $21 billion. We see 30% of that loss, but they're concentrated in small orphan indications. So we see that there's probably going to be a lot of loss in the smaller molecules because there's going to be a concentration on larger indications because revenue is going to be at a premium with IRA. And if you look at the loss of the indications, you lose 9 of 15 investment pools by indication. That's about 60% of the cohort if we look at it from the standpoint of indications. So I think I've done enough damage. I will stop now. Again, we've got a large research pack that we've worked on with Nick at Bio. It'll be dropping here in the next month or two. We're going to do a rollout of this. We'll be giving a very large presentation at Bio, which is going to be in town here in a couple months. Hope to see you all there. Please don't throw anything heavy at me, and I'm sorry. Yeah, that's where we're at, so thank you.
Thanks, Duane.
Sure.
So, Nick, on the federal level, what are the provisions of the IRA that you're hearing the most about from members, and what sort of legislative or administrative strategies are you seeing or thinking about in order to mitigate those effects?
Yeah, and you kind of alluded to this right out of the top. The biggest issue we hear about are the price controls that govern the vast majority of the losses that Duane described. It's to such a point that the inflation rebates have almost become an afterthought. No one is running into the Capitol and saying, oh my God, you got to repeal the inflation caps. We're all focused on these negotiation provisions or price controls. And I think even within that world, when we kind of look at, okay, what can we do to fix this, to solve it? Options are pretty limited for political reasons more than anything. This is a bill that was very hard fought for the Democrats to pass last year. They're not going to turn around and vote to repeal it today, tomorrow. They're going to defend it, if nothing else. We were kind of talking about before coming up here, just yesterday, a bill got dropped by Senator Baldwin to take the price controls even further, right? Right now, you have the kind of 9 and 13-year delays for your small and large molecules, respectively. They want to roll those back. They want to add to the number of drugs that are eligible to be, quote unquote, negotiated. So that's where the political tides are going. So what does that mean for what you can do to legislate to mitigate on these things? I think we're really seeing a lot of people trying to kind of find what they can do around the edges to make the totality of this bill not as bad. We far and away, the biggest thing we hear about is the impacts this is having on, particularly in the biotech community, on the ability to raise capital. You're trying to you're sitting in your pitch meeting, and you're trying to sell them on this idea that the return on investment for what is fundamentally a high risk world, as you guys all know, is now got a hard ceiling. It's not going to be the same deal. There's not going to be another Humira out there. That is no longer the world we're living in. So I think we're looking at it on the totality. I think people talk a lot about the 9-year number on the small molecules. Can we get that increased? Can you find a way to improve that? The pressures on the orphan drug provision. There is an exemption for orphan drugs. It is extremely limiting. It's actually designed in a way that would discourage seeking orphan indications in some instance, because once you have your orphan indication, your date is locked in time. And remember, these timelines are all very, very real for you in terms of your ability to generate returns on investment. So improving that orphan drug piece is really big. I think one of the other things we hear a lot about is, it's not quite as explicit in the statute, but again connects to the timeline. It is this issue of using the first active moiety. Right now, CMS is saying whatever your active moiety is, that it gets its approval. That's the one that applies for any new formulation, even if it is a radically new formulation requiring full clinical trials. You are still wedded to your very first approval date, and that is something that is, again, really putting stress on companies that are trying to do ongoing development. If you think about the way oncology works and the way R&D works in that space, it kind of makes that a little bit impossible. Are you delaying bringing your drug to market? Do you stop working on a molecule? That sort of thing are decisions that now everyone's got to make. I think the last thing I'll add, just in thinking about this, we also hear a lot about what was not included. This bill fundamentally was pretty explicitly targeted on this industry. There's no hospital provisions, no PBMs, no plans. There's nothing to require that all these new discounts get passed on to patients at the end of the day. So there's a lot of talk about, okay, can we at least find some relief in the form of actually making sure the savings get passed through to patients? Because I think the political reality is, if those savings don't get passed through, we're going to have patients right back at a town hall where someone's running for Congress, and it is going to be to their advantage to keep beating up on this industry, because the people in the audience are still going to be sitting there saying, I'm not feeling the savings at the pharmacy counter. I am still paying full freight. I still see prices being increased. And that's a loop that we've got to be able to break. Otherwise, we are going to be back at this again and again and again.
Thanks, Nick. Leslie, can you describe some of the activity that Massachusetts and other states have been doing with respect to price controls, and how you think the IRA will affect that activity going forward?
Sure. So Massachusetts generally, with respect, if you put Medicaid to the side for a minute, which I'll address in a minute, has taken a pretty holistic approach to healthcare spending with the benchmarking process that's been in place for about the last 10 years. They do look at a lot of data from insurers and hospitals and physicians across the spectrum to kind of look at benchmarking and how is that affected in the state. So that's been pretty good overall for industry. They do recognize the innovation that's going on here and how that's helping to offset costs somewhat. We also worked with them a lot to take a look more at net costs, because in the beginning they were just looking at spending and gross spending and things like that. So generally it's been a fairly good environment. We have had price control legislation proposed before, and with respect to Medicaid, they had very kind of archaic procurement in place for supplemental rebates. It had to go through the same process or RFP process as an agency buying desks or computers. And so we were definitely in favor of them changing that so they could directly negotiate with your companies. New York and California have done this for a very long time. But we strongly oppose, they took an extra step to kind of have leverage over the companies. If a favorable supplemental rebate wasn't achieved, they would want to be able to extract lots of proprietary disclosure from your companies in order to achieve that supplemental rebate. As we told the state, we didn't think that that was necessary. They haven't had to invoke that yet, which is great. They already have achieved over $100 million in savings from your companies, just negotiating in the same manner as you would with a California or New York. However, other states we've seen have been looking very myopically just at prescription drugs and have formulated prescription drug affordability boards. We have this in 6 states now. Minnesota is getting very close to passing one as well. 3 of those states can do an upper payment limit, which is looking to say, hey, you cannot charge more than this amount or purchase a drug for more than this amount in the state. They think that they're getting around federal preemption and not saying like, hey, drug, your price is this, but basically no one can buy or sell the drug in the state for more than this upper payment limit. What we are seeing is that states are looking at the IRA. They know what's going on. They are trying to plug in the maximum fair price as their upper payment limit. The Medicare, CMS is much further along in their contemplation of how the price control would work than states who have smaller staffs. So we know it's very attractive for them to just say like, hey, we're just going to take the Medicare price and we're going to apply that across all of our markets in this state. Even, I think Minnesota is even contemplating Medicare. Potentially, they think they could have it in place between when the prices are published next year and before the price control goes into effect in 26. We're also really worried about commercial spillover. As soon as the pricing is published, we expect strong PBMs really to try to leverage for in-class competition and things like that. So we are predicting kind of a downward pressure in the market even before the maximum fair price is collected. So that's what we're seeing in the states. We could potentially have Minnesota come online pretty quickly with the Prescription Drug Affordability Board. Colorado has been doing a lot to kind of put their upper payment limit in place. So unfortunately, not a lot positive to add, I guess, as far as a spillover with IRA in the states.
Thanks, Leslie. Nick, I know you mentioned the orphan drug provision as being a particular focus for your members. Duane, can you describe how the narrowness of the orphan drug exclusion will play out in the oncology space based on your preliminary findings?
Yeah, there are 2 fundamental problems with the orphan drug exclusion and the orphan drug policy, period, of IRA. The first one is if you look at who has a single asset, single indication orphan drug that's approved, generally it's a small orphan bio-based indication that doesn't have the ability to scale up and get multiple indications. So you're tied to one indication. Now you may be able to get a pediatric indication. We actually ran a model based on a real drug. We've anonymized all of this. We don't want, obviously a lot of this is very market moving. We don't want to talk about specific assets. But what we did is when we ran the numbers into this thing and then we added, okay, let's say theoretically you go from an adult indication and then you decide to add a pediatric indication with a 40% net increase of revenue. With $150 million, it's a small clinical trial spread over 3 years, $50 million a year. These are roughly real numbers that you folks are spending. What do we found? 0% increase in revenue, even with the 40% increase, because it's offset by the impacts of the reduction negotiation in the IRA. So you end up right back where you started, and you lose $150 million for the effort. This is going to be a huge disincentive. Now, there's another problem with this. If you look at the most successful oncology products right now, I will mention them because they're part of the WHO's essential medicines list. If you look at Gleevec, Keytruda, and Opdivo, you're talking about 52 indications in the accelerated approvals, primarily in the orphan space. Now, what they do is they've released as orphan drugs, and then they slowly move up into adjuvant, neoadjuvant. They move up into larger indications. But the idea has been you come in targeted at a very small orphan indication. The idea has been to go fast, okay? Because somewhere out there you have a generic. You don't know where it is. It's roughly 20, 25 years, but there's lawsuits. You don't know who's going to file claims. So you know roughly where it is, but you don't know where it starts. Now the clock starts ticking the moment you enter with your orphan indication, as Nick alluded. But here's the problem. You're trading 3 years of orphan revenue now, most of the time, for 3 years of peak revenue where you're getting reduced by 25, 35, and 60%. Now, when you calculate this out, even using an 11% cost of capital, which you all are using internally for your return on investments, you actually make less money. And we're not talking small, we're talking $500 million to $1 billion in your net present value. You lose money with the current pathway, okay? This is an enormous disincentive to oncology production. This is going to fundamentally change the paradigm with how you folks have been operating in oncology. I'm sorry, but it is. Boy, I am being rather negative. I'm very sorry about that. But look, the math is the math on this. And I've had several conversations over the last 2 weeks when we stumbled onto this. It's like, whoa, is this right? And I've had some off-the-record conversations with some clinical directors in oncology, and they're saying, yeah, you notice our last acquisition was not in oncology. This is going to have some serious impacts. This is completely unintended, but the fact is that $1 billion is a serious disincentive. And if you're losing that, you are not going to go there. It's inevitable. You actually make more money delaying by 3 years and going in with a neoadjuvant treatment in line 2 than you do coming in and salvage treatment in phase 4 and metastatic. Okay? This is going to have a tremendous impact on the sector. So.
All right, on that happy note.
On that, I'm sure it will explain it. Again, if anyone wants to give me hemlock after it beat me over the head, I completely understand. I don't take it personally. It's.
All right, so before we turn to questions, I'm going to do a quick lightning round of the panel. So Nick described there's some efforts on federal legislation to sort of limit the scope of the law, maybe in sort of discrete ways. There also are, as we've talked about, efforts at potentially broadening the law. I'm going to have everyone kind of give their perspective on the likely future of the IRA and what we'll be looking back at as its largest impact. I'll start with you, Duane.
Well, I think if we look at Tammy Baldwin's bill that was just sort of proposed, and we look at the Biden plan where he's talking about not just 1 year, but taking everything down to 5 years, I think it's game on. I think no one's going to lose an election beating up on this industry, and that's the fact. They won the midterms. They salvaged the midterm when it looked like a complete loss, and a lot of this came down to drug pricing. It's popular on both sides of the aisle. I think that this is going to keep being the winning card. They're going to keep playing until Trump's come up. Although I will be slightly positive. One quick thing. We are starting to get a lot of phone calls from some of your congressional representatives on both sides of the aisle who are actually quietly calling my firm and say, can you come in and brief us on this? We're concerned. Now, this is not a majority, but it is both sides of the aisle. And I'm not at liberty to say whom, nor would I want to. But the point is, there's starting to be a recognition that, hey, we may kill the golden goose here. So I am somewhat hopeful in that I do think there's starting to be begrudgingly recognition that we may be taking this too far. I hope cooler heads prevail. And I do think that may happen. We'll have to see.
All right, Nick, your thoughts?
I mean, I honestly, I feel very similar. We are on this trajectory where it is truly both sides of the aisle. I know we talked about IRA, which was obviously a Democratic-led effort, but there are plenty of members on the Republican side of the aisle that have recognized, like, hey, I can score points here. I mean, when Trump was president, he had a reference pricing model that he was pushing very aggressively, and it's Senator Hawley, Senator Cruz. We've seen plenty of elected officials on that side of the aisle kind of go in the same direction. I do think we are seeing some semblance maybe on the Democratic side of saying like, hey, this is a blue state industry and I'm in a blue state. Massachusetts, looking out the window. There are a lot of nice buildings representing a lot of nice jobs. Maybe we don't want to send them all to China. We want them to stay and be here and kind of grow and flourish. And I think the question is like, how do they arrest the political trajectory they're on to match the actual constituency they're representing? And that's something I still think is a policy solution everyone's grappling with. But I think that's why you start to see people kind of come around to these other policy areas where they're saying, hey, can we do something on the PBM space? There's been a lot of activity separate from IRA to get PBM reform attached to this, because I do think there are people looking at this and saying, hey, we do need to do something else in this space to curb the price issues without totally disincentivizing the innovation piece of it.
Thanks. All right.
Sure. We agree with Nick. We would love to see some action on PBMs. Massachusetts is actually one of the only states that does not regulate PBMs in any way, which is pretty surprising for a state that's not shy about regulation in other industries. So we're working on it now. As Nick had mentioned, there's definitely a hole. There's no other responsibility for supply chains and IRA. We'd love to see, the rebates be shared directly with the patients. We'd like to see changes in PBM compensation. Overall, the worry, though, is really about less innovation dollars, which will lead to access problems for patients, especially those with unmet need. My CEO, Steve Ubel, did tweet last week a kind of a prediction based on OECD, where patients have access to about 27% of new medicines there. We have right now here in the US access to about 85% of new therapies. So we do worry that we will start to slide in that direction in the next coming years as IRA pricing comes online.
All right, thank you so much. I think we can turn to questions now. And there are mics. I think there are mic runners who can, there we go.
Dare I go there? Can you describe the impact on gene therapies?
The impact on gene therapies.
It was just open-ended to describe the impact on gene therapies? Sorry, I couldn't quite hear at the beginning. I'm happy to kind of start and talk to others. I think the impact on gene therapies, I think, is actually very similar to a lot of therapeutic portfolios, in the sense that you've suddenly got immense downward pressure on these therapies, and the ability to kind of raise money and put new things into trial, into the lab, or go from the bench into clinical trial, just because the top end of the market got crammed down so aggressively. And I do think the more and more we hear about individual medicines coming out with what politicians will call very high price tags, and being very skeptical towards the value, which the gene therapy space, we've seen a lot of that kind of dynamic. I think they're going to kind of be poster children, I should say. Sorry, that was good grammar. They are going to be poster children for some of these moments, and these kind of headline moments are what drive a lot of this stuff. Duane made the reference to Humira. It was a very real thing that was something that was sticking in the back of staffers' mind as a headline moment, even if the bill itself won't get to that, because it exempts products with biosimilar competition, and Humira is going to have biosimilar competition. So as much as they see those headlines for those therapies as high priced, they're going to keep coming after them. So
the one thing I'll add to
that's my
that
guess.
is a lot of the gene therapies that are sort of in the pipeline now, a lot of them are very focused on the Medicaid population, which has its own challenges.
Yeah.
But one thing to sort of note, at least as currently set up, the IRA is very focused on Medicare, and it looks at total Medicare expenditures in order to select drugs for negotiation, and any therapy that's below $200 million a year, it won't be selected. So I think there are some gene therapies where maybe they're modeled out that they wouldn't sort of meet that threshold, looking specifically only at the Medicare program. But I agree otherwise 100% with what Nick said.
But the problem you're going to have is that how those are funded, because overwhelmingly, if we want to use a film analogy, it's the Guardians of the Galaxy that are funding the small water film, whatever the Tage of Water, or whatever it was, Tust of Tage, drink of water, I don't know. Anyway, the point is that it's the big firms that are funding a lot of these small indications. So even if the Gene therapies right now are mostly in the orphan space and orphan indication, single indication drugs. From the work we did on accelerated approvals last year that we released at Bio, we know that a lot of those, the vast majority, are not net present value positive. They're struggling to make a profit. And the problem is, if you're struggling for cash, if you're cramming down the revenue by 40%, you're going to have to make pipeline decisions. That's why in our analysis of the investment choices that we saw in Massachusetts, specifically, we did it for all 50 states, by the way, what you see is that there's going to be a selection where we can't go for these small indications. We really need to compete for these large indications now, because that's the only game we're going to have to make revenue. You've already been under pressure in these targeted indications. My fear is they're going to fall below a line in the balance sheet where it's like, we can't afford these anymore. Yeah. And I just think they don't generate enough cash. Cash is going to be at a premium now, even more than it was. And unfortunately, I just think you're going to see a lot less. Orphan drugs are going to get in a lot of trouble here, unfortunately. I hate to say it, but the math don't work anymore at the current model because you're dropping revenues by 40%. Sorry.
Any other questions? It looks like we have a question up here in the front.
Yeah, thank you. Appreciate you guys bringing this information here. Great talk. I wanted to ask maybe a two-part question. Is there any example historically that we can point to and say, like, this is what happens when you implement price controls like this, so we can say, you know, we've kind of seen this movie before? And then secondarily, like, is there any room for adaptation before we just start seeing talent and dollars flow overseas, you know, to competing nations?
I mean, I can start with a historical example. It's not maybe one-to-one, but just because it's so recent. Right before the IRA passed, the administration, working hand-in-hand with Congress, worked to pass the CHIPS Act, which was an effort to revitalize and bring back an industry to the U.S. because we'd kind of punted it away, and that was the semiconductor industry. And everyone got very concerned. This was a national security threat, et cetera, and they had to enact special legislation to attract manufacturers to reopen plants and do all that work that, quite honestly, they took for granted, which was this industry, the innovation that was around it. You know, it didn't have like the perfect example of the price control, if you will, but it was very much something where I think a lot of policymakers and legislators looked at this. They looked at it as an industry as we are entitled to this. We are entitled to this innovation and this industry staying in the U.S., not recognizing that it is a global industry. And there are certainly other players here. You know, to the cell and gene question, you know, it's not lost on me that China far and away outstripped us on cell and gene clinical trials. Like they recognize that as a spot where they can take advantage. And that's what I would worry about in this industry, and that this administration and policymakers in general don't kind of see. You sometimes see critics of the industry say things like, well, industry will never leave because we have NIH here. But if that's all it takes, then like you can certainly shack up your own version of the NIH in any country. And that's also, you know, as Duane was saying, not is provably false. But it's history that legislators are just not connecting for whatever reason, and it's really within the last year. So.
And we've even talked very much about our industry was so abundant in Europe, and once the price controls came, you know, innovation came to the U.S. We always get, you know, why are drugs more expensive in the U.S.? Because they're subsidizing the rest of the world, and so now, you know, we're going to take away, you know, take away that innovation from here, and like, where is it left to go? China, you know. But we also saw recently the Buy America, you know, like Congress doesn't like that a lot of ingredients are made overseas. Well, you know, ingredients aren't going to be made in America if we are cutting, you know, closing the door on innovation here. So unfortunately, I think, and Nick will know better than I, being more president at the federal level, but you know, those arguments are just not resonating right now for whatever reason.
There's a guy named Arthur Dammert, Professor Arthur Dammert, used to be at Harvard University just up the street here. You folks may have heard of it. He did a study in 1980 that showed that 60% of all drugs in 1980 were innovated in Europe. It's now down to 25%. This has been directly at the expense of Europe, the U.S. expansion, primarily based on the 2004 prescription drug benefit, which was designed to increase an incentive for personalized stratified oncology products in the United States. It's been a huge success, an enormous success. We released a study last November, where we modeled this based on price controls, and we looked at the pricing differentials between the United States and Europe, and we found a direct statistical correlation that could be modeled based on the price differential between the US and Europe on key performance indicators like venture capital creation, biotech creation, IP creation. You can figure it all out. Delays to market access in Europe as well. For every 10% drop, you increase 2 months the delay to access in Europe. And we could model this. And then we tested it on Japan to see how accurate the model was. We were 90 to 95% accurate in each of the KPIs, depending on which one in Japan. Running it vanilla, unadjusted. We predicted the Japanese market with 90 to 95% accuracy. So yes, we've seen this, the experiments have been run, we've seen this before. We know, unfortunately, where it ends up. And it's going to end up with less innovation. That's the reality, unfortunately. Is there time to correct? Yeah, there is. The US system's very good at self-correction. We just need to make people aware that you may win an election, but there may not be anything to win. That's the problem.
All right, I think we have time for one more question. I think her hand was up first. And we'll also stay after the panel too, so if anyone has
we got no life, we got nothing to do.
Thanks. It's my understanding there's something like 6 layers between the pharma company and the patient. Why'd we go after just the pharma part? I realize it's the high profile,
another
easy to
question.
understand, but is there more nuance to that answer?
I mean, your framing actually almost gets at the answer. You know, the way you say that. My understanding is there's 6 layers, and it's like, can you name all those players on those 6 layers? Because if you can't, that makes them bad political opponents. It's much easier to go after people that everyone knows and say, big pharma, bad. You know, it's really easy to sell that.
And it fits on a bumper
It fits on a bumper sticker. I mean, it's just like, in some ways, it's as simple as that part of it. Like, that's why you go after it. And look, I'll say something not mildly unpopular. Like, our industry has had bad actors. We're not totally blameless. There are companies that have taken aggressive price increases, set aggressive launch prices, and that has shown up on the front page of the New York Times, and that hurts the whole industry. So it's a black eye for everyone. But I do think fundamentally, I mean, if you try to explain what a PBM is and does, and versus the wholesaler, versus the distributor, versus the pharmacist, versus a specialty pharmacist, or maybe it's an association pharmacist, like, no one knows what that is, and like, you're not winning an election with that. So it's a lot easier to simply say, this company is responsible for everything. They're the bad guy. Let's beat them up and go from there.
All right, well, on that note, thank you all for coming.
Joking.
That's right. We'll stay after the panel if anyone has additional questions, and thank you all. Have a good rest of your day.
Thank you.